Hi everyone. For Chapter 9, we will discuss a small portion from the axioskeletal chapter about the 4 spinal curves and conditions involved with them. Some of those spinal curves you've learned about already in the lab, where you had to identify the 4 different types of curves on your axioskeleton lab. And now we're going to talk about a little bit about that in the first part of the lecture, very first part. And then we'll move on to types of joints and movements, which is directly related to the lab on articulations and movement. So the joint part of it is the bulk of Chapter 9, and we're just taking a little bit from the axioskeleton chapter into the first couple slides of this lecture. All right, so let's get started. So there are 4 main spinal curvatures, as you have learned from your lab on axioskeleton. The thoracic curvature, which is right here around the chest area, your thoracic cavity, and hence is named thoracic vertebrae on your backbone. It is formed by those multiple numbers of thoracic vertebrae you learn about in your lab. Now the sacral curvature, which is then close to this pelvic area, anteriorly, is formed by the sacrum bone after all the vertebrate bones. Now both of these are considered as a primary or accommodation. There's, either one is fine, but, primary or accommodation. They're known by both names because they are the ones that appear during fetal development and present at birth. So when a baby is born, they're already born with the thoracic curvature and that sacral curvature. And that's one of the reasons why newborn babies likes to be in that, scrunched up position where the baby's always doing kind of like, in this, if that's the hands, that's the feet. They're always have that really curved back, and it's because those are their primary curvature formed by this curve of the thoracic vertebrae and this curve of the sacrum. Now, the other 2 curves are the cervical curvature and the lumbar curvature. The cervical curvature is formed by the cervical vertebrae bones in the neck area right here, while the lumbar curvature is formed by the lumbar vertebrae around the lower abdominal area right there. These are considered as a secondary or compensation curves because they are developed several months after the baby is born. It is something you develop into and you grow into after the baby is born. Now, for example, in order for baby's head to hold upright on its own, that cervical curvature right there needs to have to become strong enough to hold his or her, or pretty much the baby's head up. In order for the child to learn how to walk, the lumbar curvature right here, which you can see is they tend to be bigger. Okay, so this curvature will have to develop in order to permit that full stand-up posture, so you can withstand that whole body weight coming from above your whole trunk of the body and your head. So all 4 of these curves should be fully developed for the child by the age of 10 years old. So these 2 here are what enables us to hold our head upright and also stand up straight. Okay. So usually with every chapter, other than discussing the normal anatomy and physiology, we also bring up a few common abnormalities associated with the topic. Now, over the vertebral column, which is our backbones, they are very critical to help us move, balance, support the trunk and the head. So damages to these bones, muscles, and nerves can result in distorted curves and impaired function. So we're going to talk about some of these. And hence, when something goes wrong with these vertebral bones, sometimes it can lead to abnormal spinal curves. For example, kyphosis is what we normally see and known as having a hunched back, where there is usually a hump at the back of the body like this. Can be more exaggerated, can be not so much noticeable like that, but it is a hump at the back of the body. Now, anatomically speaking, this is an abnormal posterior exaggeration of the thoracic curvature to give you that round back appearance. Because if you remember just now, we said the thoracic vertebrae is around right here, the chest area. Okay, and hence the underlying condition that can lead to kyphosis, one of it being is it can be due to osteoporosis. We have mentioned in the last chapter that when bones lose their density, they lose their strength, and hence this can lead to compression fractures. Now, sometimes these compression fractures can affect just the anterior portion of the vertebral body, such that they are squished, kind of like a little sponge, okay, at the front, just like this. For example, if you have sort of the spinous process there, and then the vertebral body there. This is the anterior end, this is the posterior end, and somehow just this area that is squished, okay, and now the vertebrae body kind of looks like this, where this front part of the vertebrae becomes compressed, and if all of them are compressed, laying on top of each other like that, so that's how you end up with that curve back you get here with the kyphosis, in the case of kyphosis. So that's how, having that compressed interior part of the vertebral body can lead to that hunchback appearance, and also why we often see this problem in older individuals where osteoporosis is more of a problem for them. Now, there can be two other underlying reasons too. One is chronic contraction in muscles on the vertebrae. Okay, so these are, we're talking about long term, not just one day you're in a bad position and next day your back ends up having kyphosis. We're talking about, for example, if we sit in a certain posture every single day for 8 to 10 hours for months, years, or if one have other work or job related things that puts you in that posture, and that particular posture puts strains on the back that can lead to those particular muscles pulling on the vertebrae bones a certain way, you can also end up with kyphosis. Now, thirdly, kyphosis can also stem from abnormal vertebral growth as well. For example, maybe when the embryo was forming within the mother's womb, something was not formed correctly in those specific thoracic vertebrae. So in this case, pretty much any abnormal vertebral growth can lead to any of the 3 abnormal spinal curves we'll talk about in this part of the lecture. Okay, so the second abnormal spinal curvature one can have is called lordosis, which is when we are bending backward like this, okay, but it's kind of like over bending backwards. Both the abdomen right here and the buttocks are, they will protrude abnormally, and anatomically speaking, this is due to anterior exaggeration of the lumbar curvature. So easy way to remember this is it starts with the L, so it has to do with the lumbar vertebrae being overly exaggerated in the curvature, where instead of just doing this slight curve, it protrudes more so anteriorly. Okay, so lordosis for abnormal lumbar curvature. Now, lordosis can be caused by multiple things, like, for example, pregnancy, abdominal obesity, or abdominal wall muscle weakness. All of them involve weight that is shifted forward and lowered. So that's why you end up with a more heavy weight at the front, and that's why you may end up with a curvature that looks like that. Or, of course, abnormal vertebral growth can be one of the reasons. Okay. And thirdly, okay, the third abnormal spinal curvature is called scoliosis. Maybe you're more familiar with this because I have heard about this more so than the other two abnormal spinal curves. I've heard of scoliosis every now and then, and I can easily remember what this represents because scoliosis start with the letter S, and the backbone kind of ends up looking like an S too, as you can see in this image here, how it curves like this. Okay, like that. So, with, kind of like, or, if someone's back is like that, then it looks more like an S. But it does that curve like that, where it reminds me, it just, to me, it sounds like scoliosis, okay, where the things are moving in that, curving one side and curve back to the other side. Now, anatomically speaking, this is due to abnormal lateral curvature of the spine, usually in one or more vertebrae, and it can actually go, either lateral to the right or lateral to the left, okay? An underlying cause can be multiple things. For example, damage to the vertebral bodies during development, like I was saying, that is always a possibility while the embryo is still forming in the mother's womb. Muscular paralysis affecting one side of the back, that can also happen because when you have muscular paralysis on just one side, then you end up not being able to move that side, which means you're going to put more muscle strain on your other side that you can move. And because you're pulling on those muscles more often and the other side you don't move at all, that can actually lead to that curvature of the spine. Kind of the same idea as what we're talking about with kyphosis, with that chronic muscle pull. Now, in this case, it's not something, a bad posture, but it may be something that you can't avoid. There was paralysis on one side for a while, and then, you've been pulling chronically on the other side. So that can also lead to scoliosis, or there can be unknown reasons too. That is always a reason, if we can't clinically explain it, then, we just say, they usually just say for unknown reasons. So sometimes that can happen too. Okay, and that's all we're going to talk about regarding spinal curves. Make sure you study and go through the practice anatomy lab on your MAP, Master AMP website to practice naming bones and joints. Because to some student, this second lab practical is the hardest lab practical because there are even more names to remember than the last lab practical. So I always remind my student to get the bones down early, so that when the muscles ID come later, you can focus on the muscles then. A lot of my students, what happened is they would cram the last minute, and they're trying to remember bones and muscles at the same time, and it's just become too overwhelming with much information. On top of that, there's still also names of joints. So there's bones, muscles, and joints. And with bones, there's bones and bone markings. Joints, there's different idea of joints, structural functional identification that we'll talk about. And with muscles, there's also there's naming of the muscle name, but there's also insertions and origins. So there's quite a bit of information to remember for this lab practical, so I really suggest for you to get started early on remembering the bone names, at least to have it down for now. And then so with the time when it comes for lab practical, bones should be a review, and then you're going to focus on trying to remember all the muscles identification. Now, I have to emphasize the use of the practice anatomy lab because that is going to kind of act like a self-test. I know we don't go over all the bone parts, but the fact that it has that interactive part where you can hide the labels and then mouse over it to know the name, that gives you a good testing of your self method than just looking at words and thinking that you got it down. But it's good to stare at a skull, and then you can name all the parts by memory of those bone names. Okay. All right, so now we'll move on to the main, topic in chapter 9, which is our joints. So just like how we have a classification scheme for tissues and bone shapes, we also have it for our joints as well. And we actually have two classification schemes. One is functional classification scheme, and the other is structural classification scheme. The functional classification scheme has to do with the range of motions, which is how freely movable is the joint Okay, how much motion can that joint do? And it's very straightforward. It's either you cannot move it, you can move it slightly, or you can freely move it. Okay, so if you cannot move the joint, it's called synarthrosis. Or we call it a synarthrotic joint if you use it as an adjective. I like to remember the S in synarthrosis as stop, which means it cannot move. Okay, so somehow when I study when I was a student, an undergraduate student, my head would make these weird relationships in my mind. And once I remember that relationship, I never forget it again, even years later. So that's what I'm suggesting you to do too as well, is to come up with a relationship about a word that makes you, once you see that word, you know what that word means almost automatically. Okay, so synarthrosis, to me, the S sounds like it's for stop. Okay, so I know that this is something that cannot move. And once it's in there, I'll never forget it once I can relate it to something. And that's the key in anatomy and physiology, when there's so much information coming at you and so many medical terminologies coming at you all at the same time. Okay, so moving on, if you can only slightly move the joint, it's called amphiarthrosis or an amphiarthrotic joint if we're using it as an adjective. I think of this as amphi, and amphi usually means a bit of both sides, kind of like, amphibian, which lives on land and water. Okay, our animals, that live in land and water organisms. So amphi being part in front of the arthrosis means it's kind of between movable and non-movable. So that's why it's slightly movable. And then lastly, you have joints that can completely move freely, and it's called diarthrosis or a diarthrotic joint. Now, it's hard to forget this one because most of our joints are diarthrotic. You will see that in lab, most of the joints we have to identify are functionally diarthrotic. So I used to tell my students, if I ask for functional classification of a joint, if you don't know what it is, just at least put diarthrotic. Maybe you're 70% of the time right. Okay, but don't go that route. Remember what the joint does. Okay, so generally speaking, our axial skeleton contains synarthrotic and amphiarthrotic joints, while our appendicular skeleton contain mostly diarthrotic joints. And this makes sense logically too, because our axial skeleton is mainly for holding and containing things. If you think about our skull, think about our ribs, they're just encasing something. While our appendicular skeleton, which is our limbs, our upper limbs, our lower limbs, they are mainly for movement that we do every single day. So that's why you want them to move. They need to move, or else we can't have any motions. Okay, so on to our second scheme. Okay, our second scheme that we use to classify joints is structural scheme. And structural scheme means something to do with the structure of the joint itself. So the structural scheme here for the joints contains three main categories along with their specific subcategories. The structural scheme is mostly named for what the joint is made up of, structurally speaking. Are they fibrous? Are they cartilaginous, meaning they're made up of cartilage? Are they made of fibers, or are they made up of something else? Okay, so the first structural type is called the fibrous joints, which mean they're held together by structural fibers of some sort. So the first specific subtype of fibrous joint is called the suture joint. Now pay attention to this part in the lecture, because when it comes to this lab, you will have to identify the joint as either fibrous or suture, and then also identify the joint by functional classification. So structural classification, functional classification, and the type of movement it does is what you need to know for the joint lab. So make sure you pay attention here. So for the suture joint, it is something that we have already slightly mentioned in the last chapter with sutural bones. Sutures only exist in the skull, and you were asked to identify a few of these in your lab, such as the coronal suture and on the interior side of the skull, and sagittal suture that bisects the skull. Okay, so those were some of the sutures you have to identify. They are functionally considered as synarthrotic, meaning that they can't move. They shouldn't. Okay, it will be kind of scary if your skull can move in and out. Okay, between those sutures, you won't want them to move anyway, because the skull is a very important sort of acting like a helmet that protects your brain. So you don't want it to move. And within those sutures, there are these dense fibrous connective tissue that interlock these joints together to keep it very sturdy and very strong. Okay. The second specific subtype of fibrous joint is called the gomphosis joint, which mainly holds your teeth to your maxillae bone and your mandible bone. Since they are supposed to bind your teeth like this, you see the teeth joint with the maxillae bone, mandible bone, and then your teeth here joining with the maxillae bone. That's the gomphosis joint. And, they're supposed to bind your teeth, so we don't want those joints to move either. It'll be kind of weird if you can easily wiggle your teeth off. So gomphosis is functionally a synarthrotic joint because you don't want it to move. Now, what I find with this chapter on joints is that a lot of it kind of works out logically, even with the motion names that we'll go through in a bit, and the names, all these subtypes we'll go over for structural classification scheme. And then, my previous students also agree that this chapter is pretty logical. What gets hard in lab is just the naming of all the joints, because some of the names doesn't sound very straightforward, and you have to be able to identify them on the skeleton. So that's a tough part on joints. And because students are usually focused on naming bones and muscles already, they forget the joints. So make sure you don't forget the joints on the lab, okay? Now, another joke I like to make about this particular joint about gomphosis is that it starts with gomp. So gomp, 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 it's kind of like moving your jaws when you're saying the gomp word. So you can think of it as related to your moving your mouth. Then you can think of, okay, that's my teeth. Okay, it's something to do with my mouth, and then that must be my teeth, and that this joint must have something to do with teeth. Okay, or you can think of it as related to your gums. Okay, gomp, G with gums, so it has to do with your teeth. So little things like that can easily help you remember the sort of some relationship with the word. And the last specific subtype of fibrous joint is called the syndesmosis, which are bones that are connected by ligaments. For example, those that bind between your tibia bone right here and your fibula bone right here. Now, this is the tibia, this is the fibula, this is the syndesmosis joint right there with the ligaments binding the distal end of these two bones together. So this joint is functionally considered as amphiarthrotic joint because they do allow slight give in movement. I'm not sure if they changed this on the digital lab manual, but in the printed lab manual, they classify this joint as synarthrotic, and I've looked it up everywhere else. Syndesmosis is amphiarthrotic. So, we're going to go with what's written down in lecture in the textbook, the amphiarthrotic. Maybe that was a misprint in the print. So hopefully maybe the digital version, they have fixed that. Okay, so this joint helps to ensure that when we move our ankles, this particular example here between the tibia and the fibula, when we move our ankles, these bones stays together. They won't all of a sudden start splitting apart within the joint. And that's, something we'll talk about when we go into the details of each two example joints that we're going to detail about. We'll learn that there are multiple ligaments that bind joints together. Remember I talked about about when I first talked about ligaments in chapter 4 tissues, I said that ligaments are kind of like ropes that wraps around the joint to make sure that these 3 or 4 or 2, bones that come together to form this joint, they just don't just all of a sudden starts falling apart, because when they fall apart, that joint no longer works as it should. So it's very critical that there are these ligaments that hold it in place and stabilize the joint in place. Okay. All right, so make sure you remember syndesmosis is part of fibrous joint, because the next two joint for the next structural type is also starts with an S, and it can get confusing between these 3 subtype of joints. Okay, so the second structural type is called the cartilaginous joint, which means these are bones. These bones of the joint are held together by some sort of cartilage tissue. So the first specific subtype of cartilaginous joint is called the synchondrosis joint. Okay, now easy way to remember this as cartilaginous is chondro. Remember, cells of the cartilage are called chondrocytes. So if you see chondro again, that automatically tells you, okay, this is a cartilaginous related thing, cartilage related thing. So that's what I mean by really looking for these little things in the words that help you remember what this stuff is. So you can never, confuse syndesmosis for a cartilaginous related thing. There's nothing in that word that says chondrocytes or cartilage. This here tells you, has a chondro word in it, related to chondrocytes, related to cartilage. And what happens with synchondrosis joint is that there is a cartilaginous bridge between 2 articulating bones. So when we talk about articulating bones, it means those bones that come in contact with each other to form the joint. That's what articulation means. Bones that come together to form the joint. So for example, the cartilage that connects the ends of the ribs to the sternum right here, it's an example of synchondrosis joint. Another example of cartilaginous joint is one we have already mentioned from the last chapter, the epiphyseal cartilage. Remember, we talked about bone growth. We talked about endochondrial ossification and interstitial growth. And we talked about how the osteocytes here kind of catch up with the hyaline cartilage, the chondrocytes forming within the epiphyseal cartilage. And that's how, a long bone grow. Okay. So that epiphyseal plate is also a joint in a sense, because there's that cartilage, bone and bone. So this cartilage here is acting as a joint that forms between this bone, this part of the epiphysis of the bone, and the diaphysis of the bone. So that's another example of a synchondrosis joint. Now, these joints are functionally considered as synarthrotic joint, not meant to move. Again, if you think about your chest, your ribs all of a sudden won't start protruding outwards or inwards. It is another joint in the back of the ribs that we'll get to later on in the chapter that allows your ribs to move upwards and outwards when you breathe in deeply. But that's not moving these joints right here, okay? And if you think about formation of a long bone, if the epiphysis starts misaligning with the diaphysis, then we're in trouble. So that's why synchondrosis are not meant to move. Okay, and then you have the third the second subtype of cartilaginous joint. So this is called the symphysis joint. This is when there is a whole wedge or pad of fibrocartilage that connects the bones of the joint. So for example, in case of intervertebral disc like this, we kind of talked about that in the tissues chapter. That piece of cartilage that connects the superior vertebrae with the inferior vertebrae is a cartilaginous joint. And then another example of this joint is what's called the pubic symphysis, which is a pad of cartilage right here anteriorly that connects the left and right os coxa together at the anterior end of the bone right by the pubis here. Remember we talked about in lab that this is the pubis, this is the ischium, okay, and this whole thing is the os coxa. Okay, so the pubis area, and that's why it's called the pubic symphysis, because it's a joint that forms between the pubis area of the pelvic bone. So the cartilaginous joints are functionally considered as, this particular one anyway, symphysis, are amphiarthrotic, which means they can do slight movement. And it makes sense because we need to bend our back and move our hips. Okay, so that's why those need to give a little bit. And in terms of the pubic symphysis, for females, it even makes more sense because the ligaments that surround this area becomes even more flexible in order for a childbirth to proceed through, because what happened is the baby's head actually have to fit through that opening within the os coxa. And that's why that pelvic bone really becomes flexible, and that's the reason why when a woman is ready to give birth, you release a hormone that relaxes all your joints called relaxin. Okay, we talk about that in the second semester when we get to the reproductive system as the last part of AMP2. But we're going to talk about that. But that part of it is what relaxes all the joints in the body, including your pubic symphysis. Okay. So the last structural type of joint is called the synovial joint, which contain the most numerous amounts of joints. We briefly mentioned this in chapter 4 when we talked about the synovial membranes. So functionally speaking, all synovial joints are considered as diarthrotic, freely movable, but they are subdivided into 6 different structural subcategories by how they look like and how they move. Okay, so the first thing I will do with this chapter, once you're done listening to my lecture, or you can pause in between, is make a little flow chart. Okay, where you have fibrous, cartilaginous, synovial. Okay, so you have I'm going to draw that really quick. So fibrous, cartilaginous, okay, and then you have synovial. And then I will split that into their subcategory type. So the first type was suture. And if you remember this if you're more a visual drawing person, then kind of do this, okay? Okay, suture, okay, and then the other one was gomphosis. So mouth with teeth, okay, very bad, just something quick that puts your mind and helps you easily remember these. And the last one was syndesmosis. And the example we gave was the distal end of the tibia and fibula joint. So maybe draw an ankle or something and the foot, okay? So you point to that, okay? Cartilaginous, you have synchondrosis, okay, and symphysis. And you can draw ribs, okay, for synchondrosis, which talking about the cartilage that binds the ribs to the sternum, and then, or the long bones, if you want to draw that. And then symphysis is, if you remember the pelvic, okay, right there, okay? So simple things like this is what helps you visualize and remember some of this already. And for synovial, there's actually going to be 6 different types, and we're going to talk about that. So start something like this on one sheet of paper, and there you go. You have almost, a good half of the chapter or something in one sheet of paper. So that's what I tell my students to do, is to make these little drawings, flow charts on your own, diagrams that can help you digest the material, and that, something you can just look back really quick at to review those topics, okay? Oh, we want to come back to presentation mode. Okay, so back at the synovial joint. Okay. So now we're going to talk about those 6 different structural subcategories later, because before I get into that, I want to go through with some of the general structure of a synovial joint, because they have a lot more features or characteristics that makes them freely movable, because we said that all of them are diarthrotic. So there's got to be more stuff for them in terms of protection and stability, because they're able to move, which means they're more likely for the bones to move out of place upon impact. So there's got to be other stuff that protects that joint. Okay, so the more exterior part of the joint, there exists an outer covering called the articular capsule, which is what this area is about. Okay, articular capsule. The articular capsule contains 2 layers. One is the inner synovial membrane, kind of like the serous membrane. It contains fluid for lubrication to ensure that smooth gliding between the bones that make up that joint. So this little pink area you're seeing right here, okay? So that's the synovial membrane right there on both sides. And then you have that whitish part you're seeing. That's the other layer, which is the outer fibrous capsule that protect the joint. And then over that articular capsule, you'll have the ligament. And that's what this part is pointing to, the ligament on the outside, which we'll get to as the accessory structure of a synovial joint. Now, all right, so now remember if you forget what ligament does, remember what I talked about with the liggy bone, okay? Liggy bone, always connect bone to bone. So ligaments bound bone and bone together, okay? All right, so those are the 2 layers of the articular capsule, the inner synovial membrane, which holds the synovial fluid for lubrication, and then that outer fibrous capsule that protects around the joint. And on top of that, you're going to have ligaments as well. All right. Articulating surfaces, like I was talking about, we're talking about articulating means bones that are actually forming the joints. They are protected by a layer of what's called articular cartilage. So this area right here and this area of the other joint. Now, the articular cartilage of bones that are forming the joint, those cartilage usually resemble those of the hyaline cartilage we talked about earlier in chapter 4. Remember, in chapter 4 tissues, we talked about hyaline cartilage, fibrocartilage, and elastic cartilage. So hyaline cartilage is what makes up those articular cartilage. And we'll come back to the idea of fibrocartilage too, because we're going to talk about those intervertebral discs towards the end of the chapter. Now, the joint usually don't have any perichondrium in this area, and they contain more water content. Okay, they tend to be slick, smooth. Okay, which makes sense because they are for gliding, smooth gliding past each other as the bone is moving back and forth, or left and right depending on the joint. But they have to have that smooth surface to reduce frictions during movement, so they don't. Technically speaking, they're not supposed to be touching each other. Cartilage and cartilage aren't grinding against each other. That's why there's that synovial fluid within the synovial membrane to keep that cushioning of the area like a little water balloon. Okay? And then the inside of the synovial membrane is the synovial fluid I was talking about for lubrication, just like serous fluid within serous membrane. Now, since remember that cartilage has no blood vessel, this fluid serves as a way for a nutrient to diffuse through to reach the chondrocytes, okay? Because there's hyaline cartilage, which means there's chondrocyte cells in there that needs nutrients. There are cells too, they need to live. So when there's not much blood vessels around the cartilage tissue, that fluid in there can be a good way to distribute and for those things to diffuse through important stuff, gases or nutrients, oxygen, etc. Now, interestingly, upon impact and compression, this fluid has the capacity to absorb shock, where if you increase the pressure, it will also increase the fluid's viscosity to brace the impact. Remember viscosity? I talked about that in chapter 4, kind of like, water versus honey or jam. They're kind of thick. It becomes that thick fluid, and the synovial fluid kind of has that ability when these two joints are smushed together, for example, in an impact, or someone's pushing you, or you fell down and you're compressing your entire weight on these joints. They will compress, and then the synovial fluid will become more viscous, acting now not a squishiness, but not like a sponge, but now acting like a harder, not, super hard, but kind of harder, malleable rubber, okay, that prevents the joints from smushing and hitting it upon each other in huge shock, okay? So that's what that synovial fluid can do. I find that very interesting that they automatically do that upon increased pressure. So that's how we're able to brace impact. Now, because synovial joints are movable, technically speaking, they're considered as the weakest of all three types of joint, or, most fragile, like I was saying, because they're freely movable. That means these bones can fall out of place or move out of place as well. So that's why they need a lot more accessory structures for that stability purposes to keep it together. If bones fall apart, then we can no longer move. For example, like our knee, if our tibia move out of place from our knees, then we won't be able to walk. So in addition to articular cartilage, there are additional pads of fibrocartilage that wedges between the articulating surface. Okay, these are called the meniscus. So this, for example, right here is a meniscus. This is a part of the meniscus as well. This was that articulating cartilage on both sides. One is on the femur. This is an example of the knee. And that's the femur, this is the tibia, and other than having these articulating cartilage, there's also extra pads of fibrocartilage, kind of like putting extra pillows there to cushion the joint. Now, surrounding the entire joint, there are also fat pads for a cushioning effect and protection. For example, this yellowish area here, wherever you see yellow in this picture is adipose tissue. Again, fats are made up of adipocytes. Okay, so we learned previously these are specific kind of connective tissue, and a lot of connective tissue are serving as package material underneath the epithelial layer. So instead of having empty spaces around the knee, which then makes it more, prone to damages and impact, there's all these fat that surrounds that joint as well to make sure that there are other stuff that cushions between all those different types of tissues. Okay, and we already mentioned ligaments, and this is the other very critical accessory feature that is needed for synovial joints to be stabilized. There are like ropes that wraps around the joint to stabilize the connection so they won't fall apart from little impacts. Now we'll talk about at the end of the chapter, if it's a large enough impact, it can cause these ligaments to tear, but that's a rare case. Okay, of course we're talking about really excessive force impacts. Okay, in the knee, for example, there are extra capsular ligament which connects the patellar bone to the tibia, and an intracapsular ligament that crisscross through the joint. So if you see this extra capsular ligament, which is pointing to this one right here, let me erase some stuff so it's not as confusing here. Let me erase all that stuff. Okay. So you have this part, which is the extracapsular ligament, and the intracapsular ligament are this middle guy right there. And we'll see how it crisscrossed through the center of the joint. Okay, they're called the cruciate ligament, which is your ACL and PCL. We'll talk about those too. They're all for stabilizing that joint. Okay, we'll get to the specific names of all the ligaments that stabilize the knee joint towards the end of the chapter. So if ligaments are torn, which is what we see happening in a lot of sports, they will heal, but usually very slowly. Okay, so it can take anywhere for weeks or even months, depending on severity of the injury, before one is ready for strenuous exercise again, if you end up with a torn ligament or damages to the ligament. For example, when one accidentally sprain a joint, they can lead to overstretching of that ligament, okay, that holds the joint in place, and collagen fibers within can tear. But the ligaments as a whole sometimes may be able to survive a strain and the joint is not damaged. Now, if it's a really forceful strain, however, the attached bone can actually break before the ligament tears. So that's how strong that bond between ligaments and bones are. So, but at least, what we know for sure is that bones would heal faster and more effectively than ligaments would. So maybe it's, it's kind of designed in our body through evolution that, our bondage for bones and ligaments is so strong that it is better for the bones to crack instead of your ligament to tear, because bones will heal a lot better than ligaments would. We'll talk about how people heal, or what are some surgical ways to replace a torn ACL at the end of the chapter. Okay, but a typical sprain is, for example, we females like to wear high heels or those wedges when we accidentally step on a rock and your ankle kind of goes, sideways. That is a sprain. And sometimes it can be okay, but if it's a really bad sprain, you end up with a limping leg, is because that sprain really overstretched some of those ligaments that hold your ankles together. And then you might, it may swell, inflame, and then you might need to rest a little bit before you're ready to walk nicely again. Okay, and the last accessory, not the last, but the third accessory structure we'll talk about is the tendons. Tendons are actually not considered as part of the joint, but they do serve to connect muscles to bones, okay? So leggy, bone, ligaments for bone to bone connection. Tendons are for muscle to bone connection. And just like ligaments, they also provide a sense of mechanical support and also limit how far we stretch a joint. So we don't end up with injuries or displacing a joint easily or really put too much strain on our muscle. Kind of like how if you're not a gymnast and you haven't been stretching yourself, you can't do a split all of a sudden just in a few hours, okay? It may take some time before you can condition your ligaments and muscles to be able to do a split, or else you're going to end up damaging those areas, okay? All right. Another type of accessory feature within the synovial joint is what's called the bursa. Okay, bursa are these green looking pockets here, or here, okay? Now, they are kind of like little water balloons that sits between where tendons and ligaments are rubbing against other tissues, like bone surfaces, for example. So, again, function is very similar to serous fluid and serous membrane for that cushioning effect and prevent friction between surfaces. Now, but over rubbing these can lead to inflammation called bursitis. Remember, itis, we talked about, means inflammation, and the word before itis usually means that's where it's inflamed. So if it's inflammation of the bursa, that's why it's called bursitis. So for example, in the case of baseball players and tennis players, we're talking a professional tennis player, baseball player, or if you're an athlete at school that does this thing all the time, they're doing hours and hours of that swinging of the arms and the same motion over and over and over again. Now that can lead to shoulder bursitis because of that consistent movement over and over again for hours and hours every single day. The other example is, if you have consistent pressure over a joint, that can be another reason to bursitis. For example, if one's job requires hours of kneeling in the same position or putting pressure over the knee, that consistent pressure can lead to knee bursitis. But other causes can also stem from infection or trauma. So these are some underlying reasons for having bursitis. Okay, either repetitive motion, pressure, infection, or trauma. But thankfully, surgery is rarely needed for bursitis. Usually one just need to give the joint some rest and some ice to cool down the inflammation. Kind of like, going back to what I was keep mentioning about homeostasis and balance. You can't overuse some stuff. It's your body's way of telling you, hey, you got to slow down because you're going to end up damaging your body. You're going to damage your tissue. So let's give you some pain to tell you to stop. You got to rest and then come back when you're feeling better so you don't put your body over the edge. Okay? All right. And then bunion is another type of condition where an actual bony bump forms over the base of the great toe, for example, like this, usually due to friction or distortion of the first metatarsophalangeal joint, which is right here. Okay, metatarsal. Remember, metatarsal are these right here. And then that joint, those are the first metatarsophalangeal joint right here in the big toe. So this often happens for females that like to wear high heels, or there's what people come up with those really cool looking shoes, but they're very tight in the front of the heel of the shoe. Oh, that is a terrible drawing of the shoe. Excuse me. Okay, right there. Okay, so that shoe, okay? So this pointiness is what's going to squish your toes together, and with chronic squishing of your toes, a bunion can form, okay? All right, so that's the difference between bunion versus bursitis. Okay, so because synovial joints are characterized by types of motions they can do, we need to talk about some of the nomenclature of different articular movements before we can get into the 6 specific subtype of synovial joint. It's just more convenient because we're going to get to those vocabularies when we get to those subtypes of joints, because, that's one way of categorizing them is how they look like and the kind of movements they can do. So the simplest articular, we call these articular motion because these are motion that are made possible by the bones that form that particular joint. So the simplest type of articular motion is the gliding movement, which is when opposing surfaces slide past each other like this. So if this pointer is my pencil, then I'm just sliding that tip of the pencil all over this platform right here. So this is exactly what it's doing. Is if you put a pencil over a piece of paper and you're just sliding the pencil forward, backward, then that's what gliding movement is. Okay, I will show a animation video that goes through these motions after we talk about the 6 different subtypes of synovial joints later in the lecture. Okay, so now on to angular movement. Angular movement, there are 3 different types of angular movement: flexion, extension, and hyperextension. Flexion is usually decreasing the angle between articulating bones. So for example, if we're talking about the elbow here, that's an articulating joint. And if we're moving your fist upwards towards your face like that, that's a flexion because you're decreasing the angle between your forearm and your upper arm, okay? But if you're putting your fists down here as in anatomical position, you're increasing now that angle to here, okay, 180 degrees. And so that's why it's called extension, increasing in angle. And then hyperextension is if you go past your anatomical position. Okay, so for example, in the leg, if we think about our leg, moving it forward would be flexion because we're talking about this hip joint right there. Let me erase the other stuff so it becomes not so messy. Okay, so you have this particular joint in the hip right here. And if you are moving your leg forward, there's your leg. So you're actually decreasing the angle between your hip bone and your leg. When you stand up straight like this, you're increasing that angle by a little more. So that extension, increasing the angle. If you move your leg backwards like this, now you're really increasing that angle even further. So that's why it's called hyperextension. But when we move our leg backwards like that. Or in terms of our neck, okay? Our neck is another joint. And if we put our chin towards our chest like that, we're decreasing the angle between our head and our chest, okay? And then if we are have our head upright like this, then the angle gets bigger, okay? If we move our head back up. And if we're moving our head backward, then we're really extending the angle towards all the way in the back like that. Okay, so flexion, extension, and hyperextension. Same thing with our wrists. We can do that as well. Flexion, angle small. Extension, somewhat little bigger. Okay, somewhat little bigger when your hand is right here. And then hyperextension, all the way backwards. Okay. And then the other two angular movement that's a little different from flexion extension is called abduction and adduction. Abduction is when you're moving away from the midline of the body in the frontal plane. For example, I like to make a joke in class. You can't see me, but when I'm in class, I do all this motion for my students in class. But imagine you're being abducted by the alien. Okay, here comes the alien. Okay, and then, I am being abducted by the alien. And then you rise up into the sky and you get abducted by the UFO, okay? So your arm is moving upwards, okay? Like, I stop. These are my hands, okay? I don't have weapon in my hand, kind of like that. So that's abduction, moving away from the midline of the body, and you're being abducted by the alien. Abduction, okay? Easy way to remember abduction, that you're raising both of your arm up, which means you're moving your body part away from the midline of your body. Adduction, 2 Ds, okay, means moving back towards the body. So abduction, adduction, okay? Or if you're doing it with your hand here, away from body, abduction, towards midline of the body, adduction. Or in your leg here, like this, according to your leg joint, abduction, away from the midline, adduction, back towards the midline. Or your wrist, same thing, okay? If it's going back towards the body is adduction. If you're moving away from the midline of the body is abduction, okay? So away or towards, okay? Abduction, adduction. And same thing with fingers too, not just thinking about your arm, legs, etc., but your fingers have abduction and adduction as well. Adduction is when you close your fingers like this, and abduction is when you spread your fingers like that, okay? Kind of together. In adduction, fingers together. Abduction, fingers apart. Okay. And then we have circumduction. This one is easy to remember. If you know what circumference is the perimeter of a circle. So that means circumduction has something to do with a circle. So you're forming this circular motion with your shoulder joint, for example. Like if you were to draw a huge circle on the board, you just need to keep your elbow straight with the chalk in your or marker in your hand, and then go do a big circle around on the board, okay? So that's circumduction, the movement of the shoulder joint around the entire area like this, okay? Or if you think about a pencil on a piece of paper, you're keeping that tip on that same area on the pencil, and you're moving that pencil like that in circles. Rotational movement then is kind of like putting your pencil on the piece of paper. You're keeping that pencil on that same spot, and then you're twisting the pencil like this, okay? Either this way or that way, okay? You're twisting the pencil on that same spot. So for us, we have either medial rotation or lateral rotation. If we think about our neck joint, when we look to our left, then that's called lateral rotation. We're going towards the side of the body. Remember, we talked about directional terms. Medial towards the trunk, lateral away from the trunk. So we're turning left, okay, or turning right from an anatomical position. Remember, anatomical position, you're supposed to be facing forward. If you're either doing left or right, those are considered as lateral rotation. So after you have turned your head left or right, for example, now you're looking sideways and you bring your head back to facing the front. That's a medial rotation because now you're moving back towards the front of the body. So turning your head this way, lateral rotation, and then turning back your head to face the front, medial rotation. Same thing with here. Okay, if we're talking about this shoulder joint right here, lateral rotation, medial rotation. Okay, lateral away from the midline, medial back towards the midline. Okay, and then more rotational movement is if we think about the joint at our elbow or our wrists. Okay, so there's something called pronation and supination. Now this again has to do with our directional terms. Okay, so prone position, remember, it means you're facing down towards the ground. Supine position means you're facing upwards looking at the ceiling. So same thing with your hands. Okay, pronation means turning your wrist and hand from palm facing towards from in the front to the back. Okay, remember, anatomical position, you're supposed to have palm facing forward. So when you turn it backwards like that, that's considered as a pronation movement. And then when you go from back of the palm, okay, back of your hand back to the palm of your hands facing anteriorly, that's a supination. So going this way is pronation, going backwards is supination. Okay, now that was talking about the joint at the elbow, okay, or the wrist, okay, but the shoulder, we're talking about medial versus lateral rotation, okay? So pronation, supination, pronation, supination, okay? Okay, and then there are many other special movements as well, and we'll mention a few of those here, different names for these movements. For example, inversions versus eversion. If we think about our ankle joint, inversion is a twisting movement of that foot which turns the sole inwards, okay? So inversion, eversion, okay? Eversion is the opposite. So inversion, your foot going inwards, like this, okay, your foot going inwards, okay, there's a terrible drawing of the foot, okay, or if eversion, then is your foot doing that, okay. Dorsiflexion versus plantar flexion, okay, so dorsiflexion, you're talking about a flexion at the ankle joint. So here's your ankle. Okay, if it's a flexion, you're decreasing, okay, decreasing the angle between. So upwards like this, like kicking a rock, you're flipping a rock up from the ground or something, kicking your foot upwards, dorsiflexion. If you're moving your leg downwards like this, it's called plantar flexion. Okay, plantar flexion. For example, if you're trying to do a tippy toe motion, that's a plantar flexion. And then you have opposition versus reposition. Opposition is when you're moving your thumb towards the surface of the palms and pads of your finger. So moving this way with your thumb, okay, touching the other fingers is opposition. If you're moving back to your open palm, okay, open palm from the opposition position back to this position, then it's called reposition. Okay, opposition, close your thumb, okay, touch your thumb to your pinky. Reposition, open back up your hands. Protraction versus retraction. For example, if you think about the mandibular joint right here, of your mandible, which is your jawline, if you protrude your chin this way, the name kind of speaks for itself, protrude, okay? So protraction, moving your chin forward, you're moving that particular body part anteriorly in the horizontal plane or moving back this way towards your body, retraction. So protraction, moving forward, retraction, moving it back. Depression, elevation. So again, this is something that kind of makes sense logically. Depression means moving a structure inferiorly. Depression means going downwards, right? So that's why you move your jaw, for example, downwards if you think about our jaw joint. And then when you're moving your jaw back to closed position, you close your mouth, that's an elevation action. So depression to open your mouth, elevation to close your mouth. And lateral flexion is when we're not talking about rotation now, not looking sideways left and right. But we're talking about, for example, when we're stretching our neck either here or here. Okay, when we're getting ready, doing warm-up before our exercise, we always stretch our neck side to side. So that's a lateral flexion, okay, where your vertebral column, specifically your cervical and, cervical part, the cervical vertebrae, okay, either bends this way or bends that way for your lateral flexion, okay? All right, so it's been an hour, so we're going to stop here and take a break, and we'll come back in part 2 of the video.